Last Tuesday morning, an ER doctor in rural Tennessee unlocked her office at 6:47 a.m., looked at the schedule, and walked out. She didn't call anyone. She didn't file paperwork. She just left her keys on the desk and drove across the state line. By noon, 47 more doctors did the same thing in hospitals across 12 states. Imagine the sound of an emergency room going silent. No heart monitors beeping, no gurneys rolling down hallways, no voices calling for assistance, just empty corridors and patients staring at locked doors with signs that read, "ER closed until further notice." This isn't a staffing shortage. This is a medical system collapse, and it's happening right now. I need you to do something. Right now, pull up a map on your phone. Search for the nearest hospital emergency room. Go ahead, I'll wait. Now, I want you to imagine arriving there at 2 a.m. with a family member who can't breathe, and the doors are locked, the lights are off, and there's a paper sign taped to the glass. How far would you have to drive to the next one? 20 miles? 50? What if that one's closed too? I'm Helen Morland. This is the Morland Report, and today I'm going to show you exactly what's happening to America's emergency medical system, the system you assume will be there when you need it. The mainstream media is calling this a temporary adjustment. I call it systematic abandonment, and the data proves I'm right. Let me show you the numbers they don't want you to see. In January 2024, there were 5,198 hospital emergency rooms operating in the United States. As of this week, that number is 4,786. 412 emergency rooms have closed their doors in the past 14 months. That's not a decline, that's a free fall. But here's what makes this different from previous hospital closures. This time, it's not the hospitals shutting down, it's the doctors walking out. I obtained internal documents from 3 major hospital networks, documents they do not want public. These memos, circulated to senior administrators in November, used the same phrase over and over: unsustainable operational environment. Translation: doctors are quitting faster than they can be replaced. According to the American College of Emergency Physicians, emergency medicine has lost 23,000 practicing physicians since January 2024. That's nearly 1/5 of the entire specialty, gone in 14 months. Where did they go? Some moved to private urgent care, some switched to telemedicine, some left medicine entirely, but the majority, according to a confidential survey conducted by the Association of American Medical Colleges, the majority said this: "I can no longer practice emergency medicine under these conditions and maintain my license, my sanity, or my safety." Let me break down what that actually means. Here's what they're not telling you about how emergency rooms actually function. An emergency room is not designed to be a primary care clinic. It's designed for acute, life-threatening emergencies: strokes, heart attacks, trauma, respiratory failure. The system assumes most people have a primary care doctor. It assumes most people have insurance. It assumes ambulances can transport patients to nearby hospitals if one is full. All 3 of those assumptions have collapsed. 74 million Americans, nearly 1 in 4, do not have a primary care physician. So when they get sick, they go to the ER for a fever, for a rash, for chronic back pain, for prescription refills. According to data from the Centers for Medicare and Medicaid Services, emergency rooms now handle more than 145 million visits per year. That's up from 110 million in 2010. But the number of ERs has dropped by 9% in that same period. You see the math here. More patients, fewer rooms, same number of doctors expected to see them all. Now, layer on this: Hospitals make money from surgeries and elective procedures, not from emergency rooms. In fact, most ERs operate at a loss, especially rural ones, especially ones serving uninsured populations. So when a hospital system is deciding what to cut, the ER is the first to go. But here's the key to everything. They can't just shut down an ER without consequences. Federal law requires hospitals to stabilize anyone who walks through those doors, regardless of ability to pay. It's called EMTALA, the Emergency Medical Treatment and Labor Act. So what hospitals are doing instead is this. They're keeping the ER technically open, but they're not staffing it. Or they're staffing it with one doctor covering a volume meant for 5. They're putting nurses in charge of triage decisions that should be made by physicians. They're diverting ambulances to hospitals 60 miles away. And when doctors object, when they raise concerns about patient safety, about liability, about the impossible conditions, they quit. Or they get fired. Let me tell you about Dr. Sarah Okonkwo, 38 years old, board-certified emergency physician, trained at Johns Hopkins. She worked in a Level 2 trauma center in eastern Kentucky for 6 years. On December 14th, she was working a solo overnight shift. That means she was the only ER doctor in the building. At 11:47 p.m., 4 ambulances arrived simultaneously. A car accident on the interstate. 3 critical patients, 1 pediatric. She had no backup, no additional staff, just 2 nurses and a medical assistant. She spent the next 4 hours trying to save lives in conditions she described as functionally identical to a field hospital in a war zone. All 3 adults survived. The child did not. 2 weeks later, the hospital administration told her she was being investigated for potential malpractice. Not because she made a mistake, because she requested additional staffing and documented unsafe conditions in her medical notes. She resigned on January 6th. She now works in telemedicine, doing video consultations for minor injuries. She makes half what she made before, and she will never set foot in an emergency room again. That hospital's ER closed 8 days after she left. Now let me show you how this cascades. When one ER closes, the burden shifts to the next nearest hospital. That hospital, already operating at 110% capacity, is now receiving ambulance diversions. Their wait times go from 2 hours to 6 hours. Their doctors go from seeing 25 patients per shift to seeing 40. Mistakes increase, burnout accelerates, more doctors quit. So that hospital cuts its ER hours. It goes from 24/7 coverage to 16-hour days, then 12 hours, then weekends only. Then it closes, and the cycle repeats. This is not theoretical. I'm going to read you a list of areas that have lost all emergency room access in the past 6 months. Custer County, Idaho, population 4,200, nearest ER 87 miles. Rural counties in eastern Oregon, over 15,000 people now live more than an hour from emergency care. Southern Mississippi, northern Maine, western Kansas, parts of the Texas Panhandle. We are watching the creation of medical deserts in real time. And it's not just rural areas. This is happening in suburbs. It's happening in mid-sized cities. In Toledo, Ohio, 2 major hospitals closed their ERs in the same week in November. That's a metro area of 600,000 people. Ambulances are now routing to Detroit, 60 miles away. Here's what the Ohio Hospital Association said in a press release. This is a temporary reconfiguration to improve efficiency. Here's what a paramedic in Toledo told me off the record. We've had 3 people die in transport because we couldn't get them to an ER in time. That's in 2 months. This is criminal. Let me show you the insurance angle because this is where it gets really disturbing. Insurance companies reimburse hospitals based on something called DRG codes, diagnosis-related groups. Emergency care is reimbursed at lower rates than elective procedures. An ER visit for chest pain might bring in $1,200. A scheduled cardiac catheterization brings in $18,000. Hospitals are profit-driven. Even nonprofits operate on razor-thin margins, so they're making a calculation. We can't afford to keep the ER open. But here's the part they're not saying. They're also betting that state and federal governments will bail them out, that there will be emergency funding, that someone else will solve the problem. That bet is failing. Let me tell you what this looks like for a patient. A 52-year-old man in western Pennsylvania, I'm not using his name for legal reasons, woke up at 3 a.m. with crushing chest pain radiating down his left arm. Classic heart attack symptoms. His wife called 911. The ambulance arrived in 12 minutes. Good response time. But the nearest ER was closed. The next nearest was on diversion. They weren't accepting patients. The third hospital was 41 miles away. He arrived 1 hour and 17 minutes after symptom onset. He was dead within 30 minutes. The coroner's report listed cause of death as myocardial infarction. But the real cause was time. If he'd gotten to an ER within the critical 30-minute window, he'd likely be alive. His widow is suing the hospital, the county, and the ambulance service, but no lawsuit brings him back. Now let me show you where this goes next. Right now, we're in what emergency management experts call the silent crisis phase. Most people don't know this is happening because they haven't needed an ER yet. When they do, they'll find out. But here's what happens in the next phase, the one we're about to enter. Ambulance services start shutting down because if there's nowhere to take patients, there's no point running an ambulance. Volunteer fire departments in rural areas are already struggling to staff EMS teams. When the nearest ER is 90 miles away, volunteers stop showing up. Next, trauma care collapses. Level 1 and Level 2 trauma centers depend on a network of regional hospitals to stabilize patients before transfer. If those regional hospitals close, trauma patients die before they reach a trauma center. Next, maternal mortality spikes. Labor and delivery is often handled in emergency departments, especially in rural hospitals. Women in active labor will be told to drive 2 hours to the nearest facility. Some won't make it. Next, infectious disease outbreaks spread faster because there's nowhere to isolate patients, nowhere to administer IV antibiotics, nowhere to monitor severe cases. And here's the final phase. This is what keeps me up at night. Mass casualty events become unsolvable. A bus crash, a building collapse, a shooting, a tornado. Any event that produces more than 10 critical patients at once. In a normal system, those patients get distributed across multiple nearby hospitals. But if there are no nearby hospitals, they die at the scene or in ambulances stuck in traffic trying to reach a facility 2 counties away. We are systematically dismantling the emergency medical infrastructure of the United States, and we're doing it quietly, without debate, without public awareness, until someone you love needs an ER, and it's not there. Let me tell you what the next 6 months look like if this continues. By June, we'll have lost another 150 to 200 emergency rooms. That puts us below 4,600 operational ERs in a country of 340 million people. By September, the physician shortage will hit critical mass. Medical schools are seeing a 40% drop in students choosing emergency medicine as a specialty. Why would they? The working conditions are dangerous, the pay is stagnant, and the liability is crushing. By the end of the year, we'll start seeing hospitals in major metropolitan areas close ERs, not just rural hospitals, urban ones, because the economics don't work, because the doctors are gone, because the system is broken. And here's the variable no one's talking about. What happens when the next pandemic hits? What happens when we have a flu season that overwhelms the system or a new COVID variant? We had 5,200 ERs in 2020 and the system nearly collapsed. What happens when we only have 4,500 or 4,000? The answer is people die. In hallways, in parking lots, in their homes, because there is no room, there are no doctors, there is no capacity. This is not speculation. This is projection based on current trends, and the trends are accelerating. So what do? First, know where your nearest ER is and know the backup and the backup to the backup. Print out a list. Keep it in your car, because when you need it, you won't have time to search. Second, if you have a primary care doctor, keep that relationship. Do not let that lapse, because if ERs collapse, primary care is all you'll have. Third, if you live in a rural area or a medical desert, consider what your plan is. What do you do if the nearest ER is an hour away and you're having a medical emergency? Do you have a plan? You need one. Fourth, document this. If you go to an ER and it's closed, take a photo, post it, share it. The only way this changes is if people see what's happening. And finally, I need you to tell me what you're seeing in your area. Comment below right now. What city are you in? Is your local ER still open? Have you noticed wait times increasing? Have you heard about closures? Because this is not a story. This is reality, and it's unfolding right now in every state in this country. Subscribe to this channel, share this video, because the mainstream media is not covering this the way it needs to be covered. I'm Helen Morland. This is the Morland Report, and we are documenting the collapse of the American healthcare system in real time. History is being written right now, and you're watching it happen.